Alright, well, welcome back. This would be our fifth lecture in the cardiovascular disorder slide deck. And it's all about 12-lead ECGs. Now, as a paramedic, you'll be responsible for obtaining and interpreting 12-lead ECGs, and in some services, based on your interpretation, activating cath labs or administering a fibrinolytic. So it's important that we get a good base on how to interpret 12-lead ECGs, and during your lab time actually spend some time looking at 12-lead ECGs and being able to identify those as well. If necessary and able, I would be happy to come down to class and go over an in-classroom lab revision of the 12-lead ECG material for you. I do teach a lot on 12-lead ECGs all across the state to many different providers. It's a passion of mine, and I hope to share some of that with you today. So the reason that we get a 12-lead ECG, a standard 12-lead ECG, is that it gives us a picture of the frontal and horizontal planes of the heart, particularly the left ventricle. It looks at the left ventricle from 12 different angles. And based on those 12 different angles that we're viewing the heart, we're able to do things like recognize left bundle branch blocks and right bundle branch blocks. We're able to identify ST segment and T wave changes that are associated with myocardial ischemia, myocardial injury, and myocardial infarction. And then we're also able to look at ECG changes that may occur as a result of medications that prolong the QT interval, or electrolyte imbalances like potassium that cause peaked T waves. Some other indications, or indications as to why we would do a 12-lead ECG, would include anybody who's got a complaint of chest pain or discomfort, specifically if during your quick assessment you determine it sounds heart-related, and we'll talk about that, or we'll talk about that in the next section. We do 12-lead ECGs to help us identify dysrhythmias. Sometimes our really fast heart rates, it might be difficult to determine whether we're dealing with SVT or VTAC, but by looking at a 12-lead ECG, we may be able to determine which dysrhythmia it is. It also gives us an idea of whether or not we've got some hypertrophy in the right or left ventricle, because we'll see certain changes to the EKG. As an example, when we have left ventricular hypertrophy or an enlargement of the left ventricle from athletic heart or from heart failure, or an enlargement of the right ventricle, right ventricular hypertrophy, that we see commonly with pulmonary hypertension and right heart failure. And then it certainly gives us a report of the heart's electrical activity before and after we provide a shock, whether it be a defibrillation or a synchronized cardioversion. If somebody suffers syncope or near syncope, and upon your arrival they're still dizzy and lightheaded, particularly if their pulse is really slow or fast or irregular, you're going to want to get a 12-lead ECG as well. Electrical injuries, it's important to get a 12-lead ECG to see if the electrical shock they received damaged the heart in any way. Strokes, the purpose we'd get a 12-lead ECG on a person who's had a stroke is to look for an arrhythmia like atrial fibrillation that would indicate the probable cause of the stroke. If we have an unstable patient of unknown etiology, we don't know why they're having chest discomfort, but they're unstable and we need to get a 12-lead ECG. Known suspected overdoses, particularly like tricyclic antidepressants. When a person overdoses on tricyclic antidepressants, you're going to see a lot of ventricular ectopy like PVCs. And then known or suspected electrolyte imbalances. As you'll see, Potassium changes what you see on the ECG, as well as calcium and sodium and those sort of things. In order to place the leads properly on the chest, there should be some sort of standard format that you go through, or some standard routine that you go through each and every time you hook up the 12-lead ECG. And here we're just talking about standard lead placement for a standard 12-lead. We're also going to address right 12-lead ECGs as well as posterior ECGs. But initially right now we're just talking about a standard 12-lead ECG. If you place your finger at the notch at the top of the sternum and you move your finger slowly downward until you have a slight horizontal ridge or elevation in the sternum, that is the angle of Louis. And if you follow that to the right, where it articulates with the second rib, you've identified the second intercostal space. So from the second intercostal space, you want to go down to the fourth intercostal space. And V1 is positioned in the fourth intercostal space just to the right of the sternum. So V1 corresponds with the fourth intercostal space on the left side of the sternum. That's your left, not the patient's left. V2 is in the fourth intercostal space just to the left of the sternum, the patient's left. From the V2 position, you locate the fifth intercostal space and follow it to the mid-clavicular line, halfway between where your clavicle attaches to your sternum and shoulder. So the mid-clavicular line, you just find the center of the clavicle, take that line down to the fifth intercostal space, and that's where you're going to position V4. So V4 goes in the fifth intercostal space, mid-clavicular line. And then V3 is positioned halfway between V2 and V4. So they've got that wrong on the slide here. V3 is positioned halfway between V2 and V4. Then you want to find the mid-axillary line along that fifth intercostal space, and V6 is placed in the mid-axillary line in that fifth intercostal space. And then V5 is positioned halfway between V4 and V6. And that's your standard lead placement. Now, if you want to do a right chest lead, 12-lead ECG, a right 12-lead ECG, then you leave V2 where it is, and that becomes right V1, and then you move, you leave V1 and V2 in the same spot, and then you pick up 3, 4, 5, and 6 and move them over to the right side in the same location in that fifth intercostal space. Okay, so here they're showing you hooking up V1, V2, V4, V3, V6, and then V5. But what you'll notice as they're noting here on the slide is that you've got V6R, V4R, V5R. You put a big R after those so that you identify to the reader that's trying to interpret this 12-lead ECG that it was a right-sided 12-lead ECG. And you see clearly here where they wrote on here right chest ECG, or a right-sided ECG, so that the reader knows to look at V4. And if V4 is elevated, if the ST segment is elevated in V4, then that tells me that the right coronary artery is occluded and the right ventricle is involved. So it would be a right ventricular MI. And those types of MIs are very susceptible to a decrease in preload. The right side of the heart isn't working well as a pump when it's infarcting, and then if you give medications that decrease the preload, like nitroglycerin, you can seriously drop the patient's blood pressure. You can also obtain a posterior chest lead placement, and this is where you put the leads across the back, just below the scapula, in a horizontal line just below the scapula. So position the patient on their side, place the V7 electrode on the fifth intercostal space, attach the V4 lead wire to V7, V8, then move V5 on the front to V8 on the back, and then move V6 on the front to V9 on the back. And that would be a left posterior lead placement. And you mark that, posterior chest left. And then you can move those same electrodes over to the right side of the chest if you want to look at the posterior portion of the right side of the heart, and then run that 12-lead ECG, but then make sure to mark that posterior chest right. Now, axis deviation is something that we need to be aware of. However, we don't really we don't pay a lot of attention to it in the field. Axis deviation refers to the location of the heart within your chest, sometimes because of enlargement, because of a congenital anomaly, injury, swelling, those sort of things. The heart may rotate or move inside the chest off its normal axis. And the axis is determined by the following steps. Leads 1, 2, and 3 form an equilateral triangle, and the heart is at the center of that. That's known as Einthoven's triangle. And then there's a hexaxial reference system where we add the limb leads, and that represents all frontal plane leads with the heart in the center. And it expresses the location of the frontal plane of the heart. The hexaxial reference system is a 360-degree circle surrounding the heart, where the positive end of lead 1, is 0, and then the frontal plane is divided into 30-degree segments. And all degrees in the upper hemisphere of the circle are negative, all degrees in the lower hemisphere of the circle are positive. And the normal electrical axis of the heart should be between 0 and 90 degrees. If current is flowing to the right of normal, that's called right axis deviation, and that's usually at plus 90 to plus 180. If the current flow is in the opposite direction of normal, out there in no man's land, that's indeterminate, it's northwest, it's extreme right axis deviation, those are words that they use to describe it. The deviation is at a negative 91 to a negative 179 degrees. And current flow to the left of normal is known as left axis deviation. Leads 1 and AVF divide the heart into 4 quadrants. So here's Einthoven's triangle, and then we have the augmented leads dividing the triangle into 6 planes, and then we have a circle. Imagine a circle around that, starting with 0 to 90 as being the normal axis of the heart. And the axis just refers to the flow of electricity. Remember, in lead 2, we're monitoring electricity from a negative pole to a positive pole so that all the complexes are upright. The P's, the QRS's, and the T's are all upright above that isoelectric line, which makes it easier for us to identify the arrhythmia. So in lead 2, you can see it's at plus 60. Where lead 1 would be at 0, lead 2 would be at plus 60, and lead 3 would be at plus 120. So lead 1 and 2, and AVF really represent the the normal axis or normal flow of electricity as it travels from the SA node down towards the apex of the heart. When we analyze a 12-lead ECG, there are some steps that we need to take each and every time. One is to assess the quality of the tracing. Is it even good enough to interpret? Is it diagnostic? If there's a lot of artifact, a lot of wave, that sort of stuff, then it really isn't diagnostic and shouldn't be used to interpret what the patient's underlying rhythm is, or certainly whether or not to administer medications like a fibrinolytic. We need to get a good quality tracing first and foremost. Then the other thing that we need to do, which isn't mentioned here, is that we need to look at the QRS. If the QRS is wide in any one of those 12 leads, if the QRS is wide, wider than normal, wider than 3 small squares, as typically we'll see with a bundle branch block, then under normal circumstances that wide QRS makes that 12 lead uninterpretable. If they've got really wide QRSs, we really can't interpret the ST changes, because really wide QRSs tell me that depolarization through the ventricles wasn't normal. So repolarization, represented by the T wave, isn't going to be normal either. So any ST segment elevation or depression that we see with really wide QRSs isn't reliable. The next thing we want to do is identify the rate and the underlying rhythm, and then evaluate the intervals, the widths and the lengths, and the things like the PR interval, the QRS width, that sort of stuff. Evaluate the waveforms, examine each lead looking for ST segment displacement, either ST segment elevation or ST segment depression, or inverted T waves. And we really don't determine the axis. It's just not something that we do pre-hospital. You can determine evidence of hypertrophy or chamber enlargement, and that's some additional information that we'll cover later concerning mimickers of STEMI, ST segment elevated myocardial infarctions. And then look for things like medication effect or electrolyte imbalance. Look at if you've got a long QT interval, find out what meds the person's on. If you've got really peak T waves, then you're thinking, the patient's potassium is high, those sort of things. And then interpret your findings or name the problem. Now, heart tissue that is ischemic, that isn't getting a good oxygen supply, that is excitable, acute ischemia is going to affect the QRS complex, particularly the ST segment and the T wave. And when we measure ST segment depression or measure ST segment elevation, we have to do so from the J point. And the J point is this spot right here. That's the J point. It's at the end of the QRS. So we measure our ST segment elevation and ST segment depression, either above or below this isoelectric line, from the J point. So the acute changes, the sudden changes we're going to see in ischemic tissue are going to be ST segment depression. So we look for that ST segment depression. Injury, actual injured heart muscle, is evident when we have elevated ST segments. So the ST segment has to be elevated above the isoelectric line. Steps to recognizing a STEMI: get that good tracing, measure the QRS width, measure the ST segment deviation, whether is it elevated, is it depressed. Because again, what you'll see with ischemia is inverted T waves. What you'll see with injury is ST segment elevation. And what you'll see with infarction are pathological cues. So as I'm looking at this example of the types of tissue damage or ischemic or infarcted, what we'll see with ischemia is inverted T waves, like we're seeing right here. or depressed ST segments, like we're seeing right here, that indicates ischemia. Injury, we're going to see elevated ST segments, like we see right here. And infarct, we're going to see Q waves, pathological Q waves. And pathological Q waves, remember here's the P, and the Q is the first negative deflection following the P. Well, this Q wave, if it's 1/3 as deep as this R wave is tall, then that's pathological. And that tells me that they've had an infarct. It doesn't tell me when they had the infarct, it just tells me that they've had an infarct. Now, for these changes to mean anything, they have to be seen in 2 or more leads that look at the same part of the heart, and those are called contiguous leads. So when we see ST segment changes, are they found in 2 or more leads looking directly at that part of the heart? If I find it only in 1 lead, it isn't significant. Okay, it's got to be at least 1 millimeter elevation or depression to be called significant, and it's got to be in 2 leads looking at the same part of the heart. So, which leads are regionalized? Which leads are contiguous? Which leads look at the same part of the heart? Well, leads 1 and AVL are the lateral leads. Leads 1 and AVL on the 12-lead ECG are the lateral leads, and they look at that circumflex artery, that branch of the left coronary artery that covers the lateral portion of the left side of the heart. Leads 2, 3, and AVF are the inferior leads, and 2, 3, and AVF look at the right coronary artery. So if I have changes in 2, 3, and AVF, that tells me that the right coronary artery is involved. Where the V leads, and if you think about placement of the electrodes, if the V leads, where they're placed around that anterior portion of the left side of the heart, those are the anterior leads. They look at that LAD. They look at that left artery descending. AVR, if you noticed in the diagram that we just looked at, there was no mention of AVR, and I was always taught that AVR is an orphan lead, that it looks off to the right when we want to be looking to the left where the heart is. It looks off to the right side, and I had always been taught that it's an orphan lead and we don't do anything with it. However, if we have elevated ST segments of greater than 2 millimeters in AVR with associated ST segment depression in leads V1 through V6, then that shows us that we have left main coronary artery disease or an occlusion. And it's a strong predictor for increased morbidity. It's a predictor for the need for an emergent CABG rather than an angiogram, or rather than a stent. CABG stands for coronary artery bypass graft, or open heart surgery. Both the LAD and the circumflex are occluded when we see this. And so these patients are acutely ill. They're often in cardiogenic shock. They often go into cardiac arrest, often before the ST segment elevation occurs. But when you do see it, if you do see elevated ST segments in more than 2 millimeters in AVR with those depressed ST segments in V1 through V6, this is evident of a significant myocardial infarction that we call the widowmaker. And only about 6% of the people survive this. So, reciprocal changes. You may have heard of reciprocal changes. And what reciprocal changes are findings in leads opposite of the affected area. So if I've got elevated ST segments in the V leads, I would expect to see ST segment depression in 2, 3, and AVF, because those are the reciprocal leads to the anterior leads. If I had elevated ST segments in 2, 3, and AVF, I would expect to see some ST segment depression in the V leads. And while not all MIs have reciprocal changes, when you do see them, it's a good indicator that what you in fact are looking at is an MI. So here are the leads, the V leads, and you can see that V1 and V2 look at the septum. V3 and V4 are anterior leads. V5 and V6 are lateral, and it's all rotating around that left ventricle. 2, 3, and AVF look at that right ventricle, and 1 and AVL look at the circumflex. Alright, so as I had mentioned, leads 1, AVL, V1 through V6 evaluate tissue supplied by the left coronary artery. 1 and AVL look at the circumflex artery, V1 through V6 look at the LAD. And so if we have elevated ST segments in any of those leads, we can determine injury. If we have depressed ST segments in any of those leads, we can determine ischemia. And if we have pathological cues, we can determine infarction. So some potential problems associated with infarcts is that lateral wall infarctions on the ECG may be anterior wall infarctions. And the reason for that is part of the LAD reaches around the lateral side of that left ventricle, where also part of the circumflex reaches around the anterior portion of that left ventricle. So it's all determined by the patient's unique coronary artery distribution pattern and collateral blood flow as to what part of the heart may be infarcting. Now, what this means to me, or what this should mean to you as well, is that we can have an anterior lateral MI. We can have an inferior lateral MI. What we cannot have is an inferior anterior MI, because an inferior anterior would mean to me that both the left and right coronary artery are occluded. And STEMI, ST segment elevated myocardial infarction, is a single vessel event. It only occurs in one vessel. Okay, so moving on. Here's your example of the epicardial coronary arteries. Epicardial just means on top of the heart. So what we call coronary arteries, some people refer to as epicardial coronary arteries. It just means they're on the outside of the heart. They supply the heart with a fresh supply of oxygen and nutrients right off the aorta. So the heart is the first tissue to receive freshly oxygenated blood. And again, you've got that LAD in the circumflex, and they bifurcate. And as they bifurcate, the pressure in those vessels is higher because they're smaller. So you think about it, as a fire truck being a high pressure pump hose, and there at the Y where it bifurcates into smaller vessels, the pressure inside those smaller vessels is higher. Anterior wall infarcts, leads V3 and V4 face the left ventricular anterior wall, and the left main coronary artery supplies the LAD and the circumflex and most of the bundle branch tissue. So when you've got an LAD artery blockage, it's called an anterior wall MI. So if you've got elevated ST segments in V3 and 4, that's more than likely the LAD. If you've got elevated ST segments in 2, 3, 4, 5, That still could be just the LAD, but because part of that LAD is going to wrap around where the circumflex is. But it's considered an anterior wall MI if you have elevated ST segments in V3 and V4. And where the occlusion is determines the seriousness. If the LAD is occluded right out of the aorta, then that not only blocks all the blood supply to the LAD, but it also blocks all the blood supply to the circumflex. So the whole left side of the heart, anterior, lateral, and posterior, receive no blood supply, or very little. They get a little bit from that right coronary artery that reaches around the back side of the heart. So depending upon where the occlusion is, determines how severe the heart attack is. And heart tissue begins to die within minutes following an occlusion of the artery, and it dies from the inside of the heart towards the outside. And it takes about 4 to 6 hours to progress. But once that tissue is dead, it does not conduct electricity, nor does it contract. So looking at this 12-lead ECG, the first thing I would do would be to look at is it a clean ECG, or is there a lot of artifact? Well, I see a little bit of artifact in 3, but it's readable, it's interpretable. The next thing I want to do is look for wide QRS complexes that are more than 3 small squares wide. And I don't see those. I don't see any wide QRS complexes. So I can go forward with this interpretation. And you see the ECG paper laid out here. And we've mentioned this already, is that on a 12-lead ECG, it's always laid out this way. Lead 1, lead 2, lead 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. So the 12 lead's always laid out this way. And what you get, sorry about that. What you get when it's laid out this way is a 2.5 second view of each lead. Now, depending on the rate, 2.5 seconds may not be a long enough view to identify the underlying rhythm. If the rate is really slow, certainly it's not enough time to identify the underlying rhythm. So many 12-lead ECGs will have 1 or 2 rhythm strips below the normal 12 leads so that you can identify the underlying rhythm. So back to my interpretation. As I look at this 12-lead ECG, my next step is to look for ST segment changes. And I see elevated ST segments in 1. I see elevated ST segments in AVL. Those are your lateral leads. They look at that circumflex artery. And then I look at leads, the V leads. And I can see some elevated ST segments in V2, V3, V4, V5, maybe a little bit in V6. It only has to be one small square. So I have elevated ST segments in the V leads, which looks at that LAD. So I have elevated ST segments in 1 AVL, V2, V3, V4, V5, maybe V6. So what that tells me is that both my circumflex artery and my LAD are occluded. So this is an extensive anterior infarction. This is the widowmaker. And if I would look at AVR, certainly if AVR at this point wouldn't be showing any elevated ST segments. But I'm also going to look for reciprocal changes. If I have all this injury going on the left side of the heart, on the back side and the right side, I should see some ST segment depression. And I do see a little ST segment depression, or at least, yeah, I see some ST segment depression in 2, 3, and AVF. So those reciprocal changes in 2, 3, and AVF seal the deal for me. I have an extensive anterior lateral infarct. Both the circumflex and the LAD are occluded. Inferior wall infarcts. With inferior wall infarcts, we're looking at lead 2, 3, and AVF. And 2, 3, and AVF view the left ventricle from the inferior side, and the left ventricle inferior wall is supplied by the posterior descending branch of that right coronary artery. What we'll also see with inferior wall myocardial infarctions is an increase in parasympathetic nervous system stimulation. So left ventricular inferior wall MIs are associated with bradycardias and heart blocks, and conduction delays are usually present as well. So with inferior wall infarcts, we're looking at that right coronary artery as it comes off the aorta, and depending on where it is occluded determines the severity of the infarct. So 2, 3, and AVF. So as I look at this 12-lead ECG, the first thing I want to do is ask myself, is it a good tracing? And the tracing looks pretty clear. I don't see a lot of artifact. Then I ask myself, is the QRS wide? In any one of these leads, is the QRS really, really wide? And I don't see that. So I know that this is interpretable, and I can keep looking for ST segment changes. Looking first for ST segment elevation. So as I look at this, I can see elevated ST segments in 2, 3, and AVF. Well, 2, 3, and AVF look at the inferior wall of the left ventricle, and in a small group of people, it may also be high enough in that right coronary artery that the right ventricle is involved. So we may need to determine that later by doing a right 12-lead ECG to rule out the involvement of the right ventricle. But right now I know it's the right coronary artery, and it could either be the inferior wall of the left ventricle, because that right coronary artery wraps all the way around the back side of the heart, excuse me, or it could also be the right ventricle. Once I have identified my elevated ST segments in 2, 3, and AVF, I know those are contiguous leads. I know those 3 leads look at that right coronary artery. They look at the inferior portion of the left ventricle. They look at the right ventricle as well. I'm looking for some reciprocal changes. I should see some depressed ST segments in either one AVL or the V leads, or both. So as I'm looking at this, I look at one, and I've got a little bit of ST segment depression. It's a little more clear in AVL, and it's real clear in V2, V1, V2. So I do have some reciprocal changes, which means these elevated ST segments that I'm seeing in 2, 3, and AVF are in fact an infarction. Okay. Lateral wall infarcts, leads 1, AVL, V5, and V6. They look at that lateral wall of the left ventricle, which is supplied mostly by the circumflex, but a little bit of the LAD reaches around there, and on the right coronary artery marginal branch that reaches clear around the back side, the posterior side of the heart, it touches a little bit of the left lateral ventricular wall as well. 1, AVL, V5, and V6 look at that lateral wall of the left side of the heart. Septal infarcts, that's where if all we have are elevated ST segments in V1 and V2, V1 and V2 look at the septum, and the septum is supplied by the LAD. So if an infarct is limited just to the septum, you'll just see changes in V1 and V2. But if the entire anterior wall is involved, then you're going to see elevated ST segments in V1 through V4. So the septum is V1 and V2. So we would look for elevated ST segments in V1 and V2 to indicate a septal MI. And the importance of knowing that it's a septal infarct is that the AV node lies in the septum. and so septal infarcts are associated with heart blocks. Posterior wall infarcts, the circumflex artery supplies the left ventricular posterior wall in most patients, and there aren't any really good leads that look at the posterior wall in a standard 12-lead ECG. But when the posterior wall of the left ventricle is infarcting, it leads to left ventricular dysfunction. It also can lead to dysrhythmias involving the SA node, the AV node, the bundle of His, bundle branch blocks, as well as heart blocks. So that's why people might do a posterior wall ECG. Pick those leads up and move them around to the back, just below the scapula on the left side, to see if they are in fact have a posterior wall infarct. Okay, and here they're identifying the posterior wall. If you see elevated ST segments in 1 or AVL or V5, V6, it might warrant picking those up and moving them to the back and see if you have elevated ST segments in V7, V8, V9. Right ventricular MIs, that right ventricle is supplied by that right coronary artery, and the right ventricle, when that marginal branch is occluded, leads to a right ventricular infarction. An occlusion of the right coronary artery proximal to the right ventricular marginal branch, then you've got an inferior and the right ventricular infarction. So depending upon where it's occluded determines whether or not it's the inferior portion, the back side of the heart, or the right ventricle, or both. So with right ventricular infarctions should be suspected when ECG changes suggest inferior infarction. So elevated ST segments in 2, 3, and AVF would indicate the presence of a right ventricular infarct. And in about 10 to 15% of the patients who have elevated ST segments in 2, 3, and AVF, you're going to see a right ventricular involvement. And those patients are going to be really susceptible to the administration of nitrates like nitroglycerin and morphine. That'll cause their blood pressure to drop significantly. Okay? So right ventricular MI is involved here, they say, in about a third of the patients. Shock resulting from right ventricular infarction is just as serious as left ventricular cardiogenic shock. And then nitroglycerin and vasodilators make this worse. In order to determine that, you do a right 12 lead. You pick those leads up from the left side, you move them over to the right side, and you run your 12 lead ECG and clearly write on there right-sided ECG. And you want to look at V4. A right V4, if that ST segment is elevated in right V4, then you have a right ventricular MI. And you know that the patient is going to be really susceptible to a drop in blood pressure should you give them nitroglycerin or morphine. What some protocols advocate is a liter or two of fluid first before giving the nitroglycerin. Some complications associated with right ventricular infarcts, certainly hypotension, cardiogenic shock, AV blocks, atrial flutter or fib, PACs. And patients with right ventricular infarcts, right coronary artery occlusion is the most common infarct, as opposed to left coronary artery occlusions. There are more right coronary artery occlusions than there are left. And the right coronary artery occlusions have a tendency, these patients have a tendency to be really sick. They're the ones that are throwing up, they're the ones that are gray, they're the ones that are that are really, really looking sick. And they just do not tolerate nitroglycerin at all. Okay? So, if that right coronary artery is occluded as it comes right out of the aorta, there's a good chance that right ventricle is involved, not the inferior portion of or the backside of the heart, but just that right ventricle. And that's going to be very susceptible to nitrates. Okay? So if I look at this right ventricular 12-lead ECG, I can see that I have elevated ST segments in 2, 3, and AVF. indicating an involvement of the right coronary artery. But then I want to focus my attention on right V4, up there in the top right. And right V4, I do have some elevated ST segment there. It doesn't have to be much. It just has to be more than one small square. And if it's more than one small square, then I know that right ventricle is involved. And I'm going to be really cautious with administering nitroglycerin or morphine. Bundle branch activation. Normal ventricular depolarization occurs in the septum, because that's where the bundle branches lie. Remember, when that impulse leaves the AV node and travels down the bundle of His, it goes into the left bundle branch first, and then the electricity traveling down that left bundle stimulates the right side as well, and then the right bundle branch conducts impulses to the right ventricle. So we can have what's called a bundle branch block. If there's illness or injury in the septum, if they've had a septal infarct, those sort of things, particularly a large infarct, it can affect the heart's ability to conduct electricity down the left bundle, which would lead to a left bundle branch block, or down the right bundle, which would lead to a right bundle branch block. And the left bundle branch conducts impulses to the left ventricle. The left and right ventricles are depolarized at the same time, and that occurs in a normal unblocked bundle branch block. But when you have a bundle branch block, it forces the impulse to travel from cell to cell through the myocardium in order to stimulate the other ventricle. And because it doesn't follow the normal conduction pathway, that conduction from cell to cell to cell, rather than through the bundle branch, slows the conduction down. So you get a wide QRS that often is notched, and that would indicate that you've got a bundle branch block. So determine the direction of terminal force if from the J point, if the majority of the QRS goes up, you're looking at a right bundle. If the majority of the QRS goes down, you're looking at a left bundle. So it's important for us to be able to identify whether we're dealing with a right bundle branch or a left bundle branch, because left bundle branch blocks, in the presence of ischemic complaints, somebody complaining of heart-related chest discomfort, and you hook them up on a 12 lead and they got a left bundle, that's highly suspicious for infarct. So in determining a bundle branch block, you want to select the widest QRS complex that has a beginning and an end. And then look at V1, because V1 is the best lead to determine whether or not you have a right or left bundle. And you use the turn signal theory. If from the J point my QRS primarily is up in V1, then it's a right bundle. Whereas if the majority of my QRS is down in V1, then it's a left bundle. Now, during a right bundle branch block, the electrical impulse travels through the AV node down the left bundle into the interventricular septum. The septum is activated by the left posterior fascicle depolarization in a left to right direction. When two bundle branch criteria are met and V1 displays an RSR pattern, you have a right bundle branch block. So, if how I know I'm dealing with a bundle branch block. One, you might have a really wide QRS, and that's going to tell you that you could have a bundle branch block. Look for QRSs that are notched, that have a notch to it, or rabbit ears. Sometimes they're so noticeable that they have what look like rabbit ears. The notch is so big it looks like rabbit ears. But look for a wide notched QRS. That tells you that you have a bundle branch block. Then the next thing you want to do is go to V1, and from the J point, if my QRS complex is primarily up above the isoelectric line, which it is, then I have a right bundle. Left bundle branches, the septum and the right ventricle are depolarized by the right bundle branch. So current away from V1 produces a QS pattern in V1, and that tells you you've got a left bundle. So again, I'm looking here at this QRS, and you can see the notch here, you can see the notch there, at the very top of the QRS. The QRS is wide, so you know you have a bundle branch block, you just don't know which one initially. So you're going to go over to V1, because V1 is the lead to look at, and from the J point, there's the J point, the QRS primarily goes down. That would be a left bundle branch block. And when you have a bundle branch block, particularly if it's new, it's caused by a STEMI in up to 15% of the patients. So it is suspicious for STEMI. But not all bundle branches are caused by STEMI. And in the past, we used to just say, you know, if you've got a bundle branch block, a left bundle branch block, and a person who's complaining of chest discomfort, then you treat it just like you do a STEMI. Well, what we found is the problem with that is that 85% of the patients with left bundle branch blocks aren't having a STEMI. And about 40% of those folks are going to end up in a cath lab and get a procedure they don't need, because we're treating left bundle branch blocks as suspicious STEMIs. So along comes Dr. Sgarboza and develops the Sgarboza criteria that we can use. And if you get a score of 3 or more on the Sgarboza criteria here, then that's 90% specific for a STEMI. And so the first thing I want to do is identify whether I have a left or right bundle branch block. And if I have a left bundle branch block, then I want to apply Sgarboza's criteria. If in any lead, any one lead, I have ST segment elevation in the same direction as the QRS, in other words, if the ST segment is elevated and the QRS is above the isoelectric line, then I score a 5. And that tells me that I have a 90% chance that this is an MI, that this is in fact a heart attack. If I don't have that, I'm going to look at V1, V2, and V3. And if I have ST segment depression in the same direction as the QRS, so if my ST segment depression is down and my QRS is down below the isoelectric line, then I score a 3. But it's got to be in V1, 2, or 3. Not all 3 leads, any one of those 3 leads. If I have ST segment depression in the same direction as QRS, there's a 90% chance that I in fact am having an infarct. If I don't have either one of those, I'm going to look at my V leads, and if I have ST segment elevation greater than 5 small squares, then I score a 2. Now, a 2 still would indicate that perhaps you have STEMI, but it's not as high a specificity. So if I look at this 12-lead ECG, the first thing I want to ask myself is it interpretable? And the answer is yes, there is no artifact. It looks nice and clean, so then I'm going to look for wide QRSs. Do I have any wide QRSs? And the answer is yes, right at about 4 small squares. And because I'm right at about 4 small squares, this normally would be uninterpretable because the QRS is wide. But the QRS is wide because of a bundle branch block. If you look at V1, you see the rabbit ears on those QRS complexes? So I've got notched QRS complexes, so I have a bundle branch block. So I'm going to go to V1, and from the J point, my QRS is below the isoelectric line. So from the J point in V1, my QRS is below the isoelectric line. I have a left bundle branch block. So now I need to apply Sgarboza's criteria. And in any one of these leads, do I see elevated ST segment in the same direction as the QRS? And I do. If I look in V5, I have elevated ST segments and the QRS is up. So the ST segment is elevated, the QRS is up. There's a 90% specificity, 90% chance that this person is in fact having an infarct. And I would treat him as a STEMI and call a STEMI alert. And this is the 2013 STEMI guidelines for the treatment of left bundle branch block. If you've got a left bundle branch block and the patient is hemodynamically unstable, in other words, their blood pressure is low and their mental status is altered, you're going to treat that as if it is a STEMI and get them immediately to a cath lab. If they aren't hemodynamically unstable, their blood pressure is good, they're awake and talking to you, you're going to apply Sgarbosa's criteria, and if it's present, then you're going to treat it like a STEMI and get them quickly to a cath lab and call a STEMI alert. If Sgarbosa's criteria isn't present, then you're going to repeat 12 leads as well as get some biomarkers, do some blood tests looking at troponin and CK and CKMB. Okay. Now with electrolyte disturbances, you're going to see certain things on a 12-lead ECG to indicate that you're dealing with an electrolyte disturbance. When a person has hypocalcemia, what happens with hypocalcemia is the ST segment is long and flat, and the ST segment is long and flat, and they have a prolonged QT interval. So if you have some sort of configuration like this with this long flat ST segment and you measure the QT interval and it's prolonged, you could be dealing with hypocalcemia. Hypercalcemia, too much calcium, what you see is the PR interval is prolonged and the ST segment is shortened, which shortens the QT interval. So if you have just the opposite, an ST segment shortened, QT interval shortened, then you would have hypercalcemia. Hypokalemia, or low potassium, the QRS complex widens as the level decreases, and the ST segment becomes depressed, the T wave flattens, a U wave develops, and the QT interval becomes prolonged. So this might be the configuration you see with hypokalemia or low potassium. You've got that prolonged PR interval, you've got ST segment depression, you've got a really shallow T wave, and the development of a normally unseen U wave. With hyperkalemia, the P wave disappears as the level increases, the PR interval remains normal, might be slightly prolonged, but the QRS complex widens as the level increases as well. The ST segment disappears as the level increases, the T wave is tall and peaked and tented, and the heart rate slows down. So when you have mild serum potassium levels, elevation in serum potassium, you see that we have peak T's and a prolonged PR segment. When you have moderate, then you lose the P wave, the QRS starts to widen, the ST segment may elevate some, and then when you have severe hyperkalemia, you have no P wave, you have a really wide QRS, and it can develop into a sine wave. And a sine wave is when the Q and the S are the same, the depth is the same as the height. So when the depth and the height are the same, equally across the paper, this patient is soon to arrest into VFib, asystole, that sort of stuff. Typically with calcium, as I just mentioned, your changes are going to occur with your QT interval and your ST segment being prolonged or shortened. With potassium, you're going to see high levels, peak T waves, low levels, flattened T waves. With hypomagnesemia, the P wave becomes diminished, the QRS complex widens, the ST segment is depressed, the T wave is flattened, a U wave is present, the QT interval is prolonged. But most importantly, prior to this, which looks a lot like hypokalemia, with hypomagnesemia, you develop polymorphic V-tach or torsades. With hypermagnesemia, you get a PR interval that's prolonged, a QRS complex that's wide, and a very tall, elevated T wave. So hypermagnesemia can look something like hyperkalemia as well. Hypothermia, when you get cold, the heart doesn't function when it's cold, so you're going to develop dysrhythmias, your PR interval is prolonged, QRS is still prolonged, your QT interval is prolonged, but your patient is cold, so you know they're hypothermic. You may have difficulty getting the electrodes to stick, and they may develop what are called Osborn waves. Osborn waves are a wave that occurs following the QRS, and it's believed that perhaps is a depolarization of the atrium, because as you see in those complexes like in V4 and V5, V6, there are no P waves. Alright, so that ends our section on 12-lead ECGs, and the only way to get good at interpreting 12-lead ECGs is to look at a lot of them. And I know as you're just learning about rhythms, that's going to be a handful for quite a while until you get really comfortable interpreting rhythms. And then your next step above and beyond that is to start looking at 12-lead ECGs. And throughout the course, particularly in ACLS, particularly in some of your upcoming labs, you will be looking at 12-lead ECGs and interpreting those. I did not cover the mimickers, and that's something that I can leave for another time, perhaps when I'm down for ACLS, or if I'm down before then we can look at maybe covering a live session with reading 12-lead ECGs and covering the mimickers as well. So if you have any questions, you've got my email as well as my phone number, so I'll talk to you soon.